I'd like to thank Arvind and Dr. Ganapati for giving me this opportunity. In fact, this has been my passion for more than a decade now, as Babsi said in the beginning. And I think it's very important for us to collect data in this country. Next slide. EMR and clinical data collection for analysis are two different things. I think this is very, very important. I really would like all to understand what an EMR is. The first speaker in the morning from US, as you all heard, said EMR is a legal document. It's a medical legal document. And with that, as a clinician, I would not like anybody to tamper with it, anybody to enter data in it, except me and my colleague who is seeing the same patient. This is absolute and it is necessary, and it cannot be done otherwise. So I think that we have to be very clear. Whereas clinical data collection, anyone can enter data. Anyone who is familiar with the data and who can extract data from the case sheet, they can enter data for analysis. This is for research purpose and also treatment patterns and ultimately to, modify the treatments for a particular population. So there are two different things. This is absolutely one should understand. EMR is a medical record and it is a legal document and it should be filled by the clinician who is treating the patient or his associates who are involved with treating the patient. Clinical data collection for analysis is something can be filled by non-medical people as well as the clinicians who are not involved with directly with that particular patient. Having said that, let's come to reality in our country. This I think is important. It's nice to see everything from all over the world, but what applies to us? That's what matters. And if it doesn't work for us, it doesn't matter wherever it works. So the hard truth in 2015, as business standard says, is we have one oncologist to treat every 2,000 patients. This is the hard truth. Next slide. And you can see this. Medical oncologists in USA, there are about 11,500 in 2014. We have 550 in this country. It may be surprising for you, the certified medical oncologists in this country are 550 in 2014. And we produce about 100 per year at the present time. Keep that in mind. And new cases, cancer cases in US is 1.6 million per year, and for us it is 1 million per year. So it is not less. We all think we have less cancer. Yes, per population, per 100,000 people, we have less cancer. But as a big population, we have a lot of new cases. Next slide. And this is the standards Canadians have put recommendations in 99, in 2000. They said for one medical oncologist in a non-teaching cancer center, there should be 173 new patients per year. 173 new patients per year. That was in 2000. Today it is much more complicated treatment for cancer patients, so they said it should be reviewed. And if you look at the US, 11,500 medical oncologists with 1.6 million patients, it comes to 130 patients per year for each medical oncologist. Keep that in mind. Next slide. When you look at this one, you can see now what happens in this country. If you see 170 new patients each medical oncologist, you need 6,000. And if we see 850 new patients per medical oncologist, we still need double the oncologists we have today. Even if only 60-70% of patients come to see the oncologist, finally in this country, let us say, not everybody sees an oncologist, then we have to see about 1,000 new patients a year. And once you see these 1,000 new patients a year, keep in mind what the time it takes and what the time he can spend with the patient. This is very, very critical. Next slide. When you look at this EMR, if you put anything in EMR other than absolute medical legal required and for patient management required data, if you want to put anything beyond that, that is a time you are taking away from the patient, from each patient. As it is, you have very little time. And in that time, you are eating away. And we should not do that. And that, I think, if we do that, there will be a lot of patients who will not have an oncologist to see. And this is across the board in all specialties, it holds good. We have 0.7 doctors per 1,000 population. US has 2.7, Canada and UK have about 2.5, and some of the European countries have 3.5 plus. So you can imagine every specialty we have the same problem. So clinical data collection, we can employ people to do that, non-medical people to do that. So they should be separate. So as I say, they are two different things and both are needed. There is no question. We should have EMRs as we go forward, but these should be kept separate. We shouldn't have the tendency to try to plug in data points for analysis later into the EMR, which will cause trouble, and the clinicians will not use the EMR because of this fear, and this time they cannot spend. So you will end up losing actually using the EMR which you want to use. There are two different things and should be kept separate in India for sure. I have no doubt in my mind, and I'm sure everybody agrees. Next slide. In '99, I started thinking about, I practiced in Canada for about 13 years and came back to India in '85. We built this cancer hospital first in Apollo in '93 in Chennai. And in '99, as I looked at it, and I felt we need to collect data to see what's happening, because the patients I'm treating are not the same, disease pattern is not the same from the West, and the treatments, the patient tolerance and the outcomes are not the same. We need to modify things for our patients. Once I find that, we need to collect data to see what's happening. And we cannot just follow the Western literature, which is most of the guidelines we follow. We do not have our own data to guidelines. Next slide. So when we collected data, as I started developing this software from that on, slowly we made the software more useful or user-friendly rather. As you can see in the first column on the top, right, left, or rather up to left, is the stage per disease as the presentation. And in the next to that, you can see the presentation over 2 periods, 5-year periods, and the lymph node disease has come down. That means the patients are coming at earlier stage, which is a good sign. Of course, I work in a private corporate hospital where educated and wealthy people come. So naturally, they are more aware of things and they come at an earlier stage. At the left bottom, you can see the pattern of practice. And you can see the red is one of the new drugs that came along, and slowly we adapted it as we could build up our the tolerance of our patients, judge the tolerance of our patients, and also the efficacy in our patients. And finally, by the end of 2008, we are using on almost all the patients, as against 99 when we were not using very few patients. The next one you can see is the follow-up of the patients. All this can be done in few minutes from the database we can collect in this software. Next slide. And you can also develop the actually survival curves. And these are all done by a simple statistical package called MedCalc, which is from Belgium. And this one is actually the top left. You can see by stage what the survival is, and stage 1 and 2A breast cancer patients have something like 90 to 95% 10-year relapse-free survival. That means they are not recurred. Next to that, you can see by the type of treatments we are given, and this is crucial slide, because you can see between the treatments we changed over the years of that 10-year period, there is not a lot of difference, maybe 2-3% here and there. Then we can have a choice. We can see between these, the best and the worst, what is the cost difference, and what is the complication difference, and what facilities you need to give the best and the worst, and what is the difference in survival. All these need to be analyzed in our socio-economic and political system and the geographical system. And the left and the bottom, you can see from this software, you can subdivide these and come into a very small segment of very special, a niche population of patients and see what happens to them with the treatment. And the next one is, of course, at 5-year patterns between the survival. The bottom curve is the first 5 years, the upper curve is the next 5 years, and that probably is the reflection that the lower stage and also the new drugs we used. Next slide. So this is the OncoCollect TM. Next slide. And this is a software. What basically does is a localized database. It remains with the individual institutions, and it can enable for pooling in the cloud without patient identity information, encrypted patient data, and also flexible dynamic data elements, and response design and medical coding. Internally, we can code these or group them and export to Excel and cloud without patient identity, and built-in formulas to facilitate analysis. Next slide. And the structure is ABCD is basically institutions with their own database, so their database stays with them. If they don't want to partake with their database, they don't have to, but they can analyze in their own institution how it is working and what not working. And in the first institution, as you can see, on the top, the blue cloud is where the master database is maintained by the trust, and from there they can download any updates that are made to the software. And next, the white cloud holds number of databases which are actually study databases, where people can pull together the data for different diseases, different populations, and see what is happening with them. And this can be done between institutions. For example, BC can become one group, CD can become one group, and DA can do another cancer, breast cancer, and so on and so forth. And the principal investigator of that study will have the rights to download the pooled database. And of course, the pooled database does not contain either the patient identities or the doctor identities. It will only trace it back to the institution. Next slide. So that is basically the structure of it. And for this, we created a trust. It's a Ramesh Nimmagadda Cancer Foundation, which I felt is, unless we do something in a public interest and a general thing, this cannot be done in a commercial basis. This is for the country in terms of deciding what our patients need, because our patients definitely in practice are different from the Western Caucasian patients, which is where the most data is available. So this is to establish a common platform and enable individual institutes to form groups and pool data. And more importantly to me is enable easy analysis of this data, easy analysis. Without a statistician, physician should be able to analyze broadly, unless he wants to do a intricate statistical analysis. Enable easy analysis of the data, both individuals and the institutions, to constantly refine their treatments to suit their local conditions. That's again important. As earlier was said, Europe is so many countries, and they said so many languages. I keep telling them their alphabet is the same. And whereas in India, when we say languages, we truly are different languages. Our alphabet is different. So we are so diverse. And ethnically also we are diverse. Northeast is different from South and North. And we all have to look at it. And also the infrastructure at different places is different. And these are all important, because at least in oncology, the treatment can kill patients. Let me be very frank. It is dangerous treatments. Of course, disease is dangerous, but you have to treat. So you have to be extremely careful. For local conditions, you can analyze your own data and see what is the best for that population in that institution and in that conditions. And the vision is to create a repository of Indian data on treatment and outcomes, not just the demographics. I'm looking at treatment and outcomes to formulate India-specific treatment guidelines. At present, we formulate guidelines based on the Western data, Western guidelines, and some few old people like me sit and say, experienced, and say that we should be doing a little different this and that, and say this is our guidelines at the end of the day. And so we should formulate based on Indian data, and we have to collect that. Next slide. And today we say we are developing an emerging economy, and we have no excuse to say we do not have money, resources to collect data. We have to do that. And so far we have installed it in 7 institutions: Apollo Specialty Cancer Hospital in Chennai, Mahavir Cancer Sansthan Patna, Tata Medical Center Calcutta, Basatark Indo-American Center in Hyderabad, Rajiv Gandhi Cancer Center in Delhi, and Chennai Breast Cancer Center, and GKNM Hospital in Coimbatore. And between these hospitals, they see approximately more than 1 lakh of new patients per year. And you see, this is the kind of data we can get. And of course, this is also accepted by the National Cancer Grid. At the last 6 months, we have done that, and 3 papers are going to be presented, 2 from Chennai Breast Center and 1 from Tata Medical Center in the 6th to 8th November national meeting in Mumbai. And lastly, OncoCollect is owned by RNCF and is provided free of cost to all involved with treatment of cancer in India and willing to collect clinical data, which I think is very, very important. And we have to do it, and this is not going to happen in 6 months, 1 year. Oncology data comes, matures over years. You need 3 to 5 years, depending on the cancer you are looking at. So one has to be patient, but has to collect data. And this software can collect minimum data and also can do elaborate studies with 100 fields. Whereas if we collect 15 minimum fields, which I created for every institution, for every patient, we have data something can beat by numbers itself. We will have the p-value powers and make our own guidelines for our patients. And this helps because if we find a lower treatment at a lower facilities can be given, a lot of patients can be treated in their hometowns, doesn't have to come to cities and spend a lot of money. And this in a socioeconomic situation in our country, we all owe to these patients. 80% of patients, our population, cannot come to a city and stay for 6 months for a cancer treatment in this country.